Hello everyone, and welcome to another reading of Advanced Pathophysiology. Today we're going to talk about Chapter 34, the alterations of cardiovascular function in children. However, we are skipping over a small portion here. Um, I think I'm just going to be doing the congenital heart defects, the classification of the congenital heart defects and associated conditions, defects increasing pulmonary blood flow and decreasing pulmonary blood flow, as well as the obstructive defects and mixing defects. I may jump into these last 3 pages here as well regarding the acquired cardiovascular disorders, your Kawasaki disease, systemic hypertension and childhood obesity. I will be jumping over the cardiovascular system though, the developmental anatomy, transitional circulation, and closure of fetal shunts, as well as the postnatal development. Again, my pages are a little different than in the book, but we'll jump right into it here. 3548. So we'll jump right into it. So, congenital heart disease, or CHD, is the leading cause of death, excluding prematurity, during the first year of life, according to box 34.1. There are more than 35 documented types of congenital heart defects, and the frequency of occurrence in the US continues to rise. Although researchers have not determined the reason for this increase, one explanation is that it may be the result of improved methods for early detection. So, children with congenital heart disease are at risk for developing endocarditis. Although the risk is low, a transient bacteremia has been noted to follow dental and surgical procedures and instrumentation involving mucosal surfaces. A blood-borne pathogen can inhabit areas of the heart where there is high turbulence, such as an abnormal valve or a vessel, or reside on artificial material, such as a valve or a homograph. Streptococcus viridien, an alpha hemolytic streptococci, is the most commonly found pathogen following dental or oral procedures. Enterococcus facilis, or enterococci, is the most common bacterium found following genitourinary and gastrointestinal tract surgery, or instrumentation. The American Heart Association has provided updated guidelines for the prevention of bacteria or bacterial endocarditis. The type and dose of antibiotic prophylaxis recommended depend on the procedure and cardiac classification of the risk for endocarditis. Good dental hygiene with daily brushing and flossing is critically important, along with regular dental checkups. So how does this, I don't think this was actually the part that I needed. I think this was, no, this box 34.1. There is more though. So what's new? The screening for critical congenital heart disease. Some newborn infants with severe congenital heart disease may appear to be physically normal without cyanosis or significant heart murmur, but may become critically ill or even die when fetal shunts close, usually after discharging home. The U.S. Department of Health and Human Services added pulse oximetry screenings for critical congenital heart disease to the recommended uniform screening panel for all newborn infants. The requirement is a pulse oximetry recording from the right hand preductal and 1 foot postductal, 24 hours after birth or prior to hospital discharge. A pulse oximetry reading less than 95 in either site is more than 3% difference between hand and foot means a positive or failed screening. If failed, the screen is repeated, and if failed again, the infant should be evaluated and undergo a diagnostic echocardiogram prior to discharge. And that is approved for 43 states and had enacted legislation, regulation, and hospital guidelines Studies are underway to evaluate the effect of the screening on CHD morbidity and mortality. The underlying cause of CHD is known in only 10% of cases. Several factors place the fetus at risk for developing CHD, including prenatal, environmental, and genetic factors. Among the prenatal factors are maternal rubella, maternal insulin-dependent diabetes, maternal lupus, maternal alcohol or illicit drug use, maternal age older than 40, maternal phenylketonuria, so ketones in the urine, and maternal hypercalcemia. The use of some drugs during pregnancy is associated with an above-average incidence of CHD. Examples of these drug teratogens include anticonvulsants, angiotensin-converting enzymes or ACE inhibitors, lithium, retinoic acid, and warfarin. The incidence of heart defects also has been found to be higher in stillbirths, spontaneous abortions, and low birth rate or small for gestational age infants. In general, the likelihood of unaffected parents having a child with CHD is about 1%. The risk of recurrence in a sibling is approximately 3%. However, this may vary depending on the type of CHD. Genetic factors also have been implicated in the development of CHD. Although the mechanism of causation is often multifactorial, recent progress, accelerated through the Human Genome Project, has resulted in the rapid identification of many genes causing CHD. So the etiology behind it is the etiology of most CHD is unknown. Early epidemiologic studies report a multifactorial influence to be the cause of up to 90% of cardiac anomalies. Associated risk factors include maternal, gestational, and familial conditions. Exposure to teratogens in utero also may be a risk factor. Likewise, fetal exposure to active maternal infections such as rubella, herpes, Coxsackie virus B5, and the cytomegalovirus may be a risk factor. Chromosome aberrations account for about 6% of all CHD. Many genetic and hereditary diseases are associated with CHD, although the mechanism and causation is still unknown. As many as 50% of infants with trisomy 21 have a CHD, usually either an AV canal defect or a VSD. Non-cardiac defects are noted in as many as 35% of infants with cardiac lesions. Prospective studies using chromosomal analysis have suggested that congenital cardiac malformations may be the result of a single gene defect. So then there's some syndromes here and where they occur. Let's skip right through those then. Because of the improved screening method, surgical intervention, and management, children with congenital heart defects are now surviving into adulthood and bearing children of their own. Studies report up to 15% incidence of CHD in offspring of a parent having a congenital heart lesion. Subsequent siblings could have as high as a 50% chance of having a cardiac malformation. The classification of congenital heart defects and associated conditions. There are more than 35 different types of congenital anomalies that can be classified into 4 categories based on blood flow patterns. Lesion increasing pulmonary blood flow, lesion decreasing pulmonary blood flow, obstructive lesions in which right or left-sided outflow tract obstructions curtail or prohibit blood flow out of the heart, and mixing lesions in which desaturated blood and saturated blood mix with the chambers or great arteries of the heart. By classifying lesions in this way, the clinical manifestation as well as associated sequelae, are more predictable. So then there is a classification of congenital heart defects here. Lesions increasing pulmonary blood flow, the left to the right, can cause a cyanotic congestive heart failure. And the specific defect is the patent ductus arteriosus, arterial septal defect, ventricular septal defect, a complete atrioventricular canal defect. Lesions decreasing pulmonary blood flow, the right to the left, you are cyanotic, and the specific defects are a tetralogy of Fallot, a tricuspid atresia. Obstructive lesions, there's no shunt direction, but there's low cardiac output, which leads to shock, coarctation of the aorta, aortic stenosis, or pulmonary stenosis. And then mixed lesions could be variable, the presentation is variable, but pretty much the transposition of the great arteries, total anomalous pulmonary venous connection, a trancus arteriosus, hypoplastic left heart syndrome could be all a factor. Associated conditions and their clinical manifestations are lesion dependent. The two most common conditions associated with CHD are heart failure and hypoxemia. Lesions increasing pulmonary blood flow include defects that allow blood flow to shunt from the high pressure side to the lower pressure side, resulting in pulmonary congestion. Lesions that cause decreased pulmonary blood flow are generally complex and result in cyanosis. Obstructive lesions increase the pressure needed to eject blood from the ventricles. The two types of obstructive lesions are right-sided lesions that may result in hypoxemia and cyanosis. The left-sided lesion that may result in heart failure. Mixing lesions are variable in their physiology and clinical manifestations. Leading us into heart failure. Heart failure is a classification as an acquired condition. Heart failure occurs when the heart is unable to maintain sufficient cardiac output to meet the metabolic demands of the body. Heart failure can occur as a result of decreased myocardial function or excessive metabolic demands. The most common causes of heart failure in infancy and childhood are cardiomyopathy or the result of poor ventricular function. The table here lists the congenital heart defects that may cause heart failure by age. Pulmonary overcirculation from left to right shunts, mixing, is often called congestive heart failure, but is not usually associated with decreased cardiac output and failure to meet metabolic demands. However, the clinical manifestations are similar, such as a failure to thrive, tachypnea, tachycardia, and respiratory tract infections. So, there are congenital heart defects caused by heart failure. From time of birth, there is a hypoplastic left heart syndrome, volume overload caused by the tricuspid regurgitation, which is rare, and arteriovenous fistulas. From birth to the first week, there is also a hypoplastic left heart syndrome, aortic atresia, a transposition of the great vessel with ventricular septal defect, coarctation of the aorta, total anomalous pulmonary venous connection with obstruction, and patent ductus arteriosus in premature infants. The first 4 weeks, there are coarctions of the aorta, TAPVC, or total anomalous pulmonary venous connection, a large left to right shunt caused by VSD or PDA in premature infants, tricuspid atresia, persistent truncus arteriosus with large left to right shunt, and all previously mentioned defects. Well, that's great. And 4 to 6 weeks, transposition of the great vessel with VSD, large left to right shunt caused by endocardial cushion defect. 6 weeks to 6 months is usually VSD, whereas 6 months it's a endocardial fibrinoelastosis. So our pathophysiology for our heart failure. In general, the pathophysiological mechanism of heart failure in infants and children are very similar to those in adults. The same compensatory mechanisms are activated in the face of inadequate cardiac output. An acute decrease in blood pressure stimulates stretch receptors and baroreceptors in the aorta and carotid arteries, which in turn stimulate the sympathetic nervous system. With the release of catecholamines and the stimulation of beta receptors, heart rate and the force of myocardial contraction increase. Venous smooth muscle tone also increases, which increases return of venous blood to the heart. Sympathetic stimulation also decreases blood flow to the kidneys, skin, spleen, and extremities, so that maximum flow to the brain, heart, and lungs can be maintained. Decreased blood flow to the kidneys causes a release of renin, angiotensin, and aldosterone. If chronic, this cycle results in retention of sodium and fluid by the kidneys, which in turn increases volume in the circulatory system. These neurohumoral and hemodynamic changes create abnormal ventricular wall stress and cause the myocardium to hypertrophy. After excessive hypertrophy, the myocardial fibers begin to stretch and accommodate the increased volume. Hypertrophy and fiber stretch temporarily increases contractility, and hence the force of ventricular contraction. However, these mechanisms eventually fail to maintain cardiac output as heart failure progresses. A review of the Frank-Starling law of the heart in Chapter 32 is useful for an understanding of the cycle of compensation and decompensation that occurs in heart failure. Our clinical manifestations. Symptomatic heart failure in children has many causes. It is not usually necessary to determine if it is right or left-sided heart failure. When assessing a child with heart failure, a combination of symptoms generally is present. Pulmonary overcirculation is the predominant cause associated with congenital defects. Heart failure in infants is manifested as poor feeding and sucking, often leading to failure to thrive. Dyspnea, tachypnea, and diaphoresis may be accompanied by retractions, grunting, and nasal flaring. Wheezing, coughing, and virulence are rare, and even with significant heart failure. Common skin changes, such as pallor or mottling, are often present. Hepatomegaly, or an enlargement of the liver, is atypical attributable to systemic venous congestion. In infants, the normal liver is soft, sharp-edged, and palpable to 1 to 2 centimeters below the costal margin. However, absence of hepatomegaly does not rule out heart failure. Periorbital edema and weight gain without caloric increase are uncommon manifestations of right ventricular failure in infants. Peripheral edema, which is a common finding in adults, is rare in infants and young children, and more often signifies renal disease rather than cardiac disease. The clinical manifestations of heart failure are listed in box 34.2. So, for instance, our impaired myocardial function is tachycardia, pulmonary congestion is tachypnea, and our systemic venous congestion means there is weight loss. Whereas if our impaired heart function is sweating inappropriately, the pulmonary congestion is dyspnea, and our systemic venous congestion is hepatomegaly. If due to our heart failure we have a decreased urine output, our pulmonary sign shows retractions, and systemically it may show peripheral edema, which is extremely rare. If, however, our cardiac symptom is fatigue, we may see some nasal flaring and in our pulmonary aspect, and systemically overall ascites. Impaired myocardial function is weakness. It may show exercise intolerance in our pulmonary congestion, and we may see some neck vein distension. The same goes with if we have restlessness. We, however, may have orthopnea, but still the neck vein distension. If our cardiac function or malfunction rather is anorexia, they may have a continuous cough or hoarseness. If they're pale or have cool extremities, our pulmonary aspect might be cyanosis. If they have weak peripheral pulses, then pulmonary-wise they might have AVs. If they have a low blood pressure, our pulmonary congestion may show grunting. And then we also have a gallop rhythm or cardiomegaly. So there are quite a series of clinical manifestations. And somehow I have a feeling that none of those correlate with one another. That really these were just a list of all the types of conditions that could occur, and no correlation whatsoever. So what is our evaluation and our treatment? Well, a thorough physical examination with an emphasis on cardiac and pulmonary findings often will reveal the degree of heart failure. Plotting the child's growth, our height, weight, and head circumference is an important method for monitoring a child's health. Infants with heart failure and pulmonary overcirculation usually have a low weight with a normal length and head circumference. Failure to thrive is usually the result of increased metabolic expenditure relative to caloric intake. Increasing caloric density or NG tube feeding, or both, may be necessary to optimize caloric intake to promote weight gain. An EKG should be performed to determine the presence of dysrhythmias or hypertrophy. A chest radiograph is useful in assessing the presence of cardiomegaly and signs of increased pulmonary circulation. However, EKGs is the gold standard for definitive diagnosis of structural and functional cardiac disease. Treatment is aimed at decreasing cardiac workload and increasing the efficiency of heart function. Medical management initially consists of diuretics such as furosemide, depending on the degree of heart failure. Other diuretics can be used in combination with Lasix to counteract potassium losses. Agents that reduce afterload, such as ACE inhibitors, angiotensin receptor blockers, and beta blockers, are used to further manage severe heart failure. In severe cases of heart failure, anticoagulation and mechanical circulatory support may be indicated to support the failing myocardium. Hypoxemia. Heart defects that allow desaturated blood to enter the systemic system without passing through the lungs results in hypoxemia and cyanosis. Hypoxemia occurs when arterial oxygen tension is below normal and results in low oxygen, arterial saturations, and cellular function alterations. Cyanosis, a blue discoloration of the mucous membranes and nail beds, results from deoxygenated hemoglobin in a concentration of at least 5 grams per deciliter of blood or from arterial saturations less than 85%. Anemia may mask the signs of hypoxemia, whereas children with a polycythemic with a normal arterial saturation may appear cyanotic. Older children who have an unrepaired septal defect with a left-to-right shunt may become cyanotic because of pulmonary vascular changes secondary to increased pulmonary blood flow. Because of these progressive pulmonary vascular changes, PVR increases to exceed or equal SVR, resulting in a reversal of shunting known as Eisenmenger's syndrome. Three types of defects cause hypoxemia and cyanosis. Lesions that cause ventricular outflow, tract obstruction, and shunting from the right side of the heart to the left, as in tetralogy of Fallot. Defects involving the mixing of saturated and unsaturated blood within the heart chambers, as in a univentricular heart. And defects in children with transpositional of great arteries, in which two parallel circulations exist and survival depends on the existence of a patent ductus, arteriosus, or septal defect. So what are our clinical manifestations? Well, infants with mild hypoxemia may show signs of cyanosis only, occasionally when stressed. Otherwise, they may exhibit near normal age projected growth and development. Infants with severe hypoxemia may display signs of feeding intolerance, poor weight gain, tachycardia, and dyspnea. Children with chronic hypoxemia are small for their age, may display cognitive and motor skill delays, experience shortness of breath with exertion, fatigue easily, and have exercise intolerance. Acute severe hypoxemia will lead to tissue hypoxia, metabolic acidosis, hyperventilation, poor perfusion, and eventually shock. In response to chronic hypoxemia, polycythemia occurs as the body generates additional red blood cells to increase the oxygen-carrying capacity of the blood. In some infants, however, microcytic anemia may result because of limited stores of iron. Polycythemia, or hyperviscosity, and the associated platelet dysfunction also place children at risk for thromboembolic events, especially infants with severe cyanosis and iron deficiency anemia. Children with right-to-left shunting are at risk for systemic embolic events, cerebrovascular accidents such as strokes, and brain abscesses. Clubbing of all the nail beds occurs because of the chronic tissue hypoxemia and polycythemia. So defects increasing pulmonary blood flow. Cardiac lesions that increase pulmonary blood flow include defects that involve septal abnormalities or communication between the great arteries. These allow the shunting of blood from the high pressure left side to the lower pressure right side. Infants with left to right shunts are acyanotic and, depending on the degree of shunting, may develop signs of symptoms of heart failure. Children with significant left to right shunts, left untreated, are at risk for developing irreversible pulmonary hypertension. So then we have a patent ductus arteriosus. It is a vessel located between the junction of the main and left pulmonary artery and the lesser curvature of the descending aorta, usually just distal to the left subclavian artery. During fetal circulation, the PDA allows blood to shunt from the PA to the aorta. At birth, once the placenta is removed and the lungs are expanded, the PDA in full-term infants is usually noted to be the... I'm sorry, I lost my spot. The PDA will start to constrict within the first hours of life. Closure of the PDA in full-term infants is usually noted in the first few weeks of life. As an isolated defect, PDA occurs in 5 to 10% of all CHD, but the incidence of PDA is much higher in preterm infants because of the high circulating levels of prostaglandins and immature pulmonary vascular smooth muscle. So here we have the patent ductus arteriosus. and it shows how there's an increased volume from the lungs from the left side of the heart. So our pathophysiology. Failure of the PDA to close results in persistent patency of the ductus arteriosus. The hemodynamic effects of PDA depend on the size of the lumen and the resistance in the pulmonary and systemic circulations. At birth, the PVR and SVR are almost equal and are reflected in the PA and aorta, respectively. Therefore, shunting is minimal. However, as PVR falls, a reversal of fetal shunting occurs. Blood now begins to shunt left to right from the aorta to the PA. The hemodynamic effect is increased pulmonary blood flow, resulting in increased pulmonary venous return to the LA and LV, with increased workload on the left side of the heart. The increased workload is caused by increased pulmonary venous return to the LA and potentially an increase in right ventricular pressure if pulmonary vascular changes occur in response to increased blood flow, leading to an increase in pulmonary vascular pressure. So what kind of clinical manifestations do we see? Well, if the PVR has fallen, infants with PDA will characteristically have a continuous machinery type murmur heard best at the left upper sternal border throughout systole and diastole. If the PDA is significant, the infant will have bounding pulses, an active precordium, a thrill-upon palpitation, and signs and symptoms of pulmonary overcirculation. Infants with a small PDA will usually remain asymptomatic. So our evaluation and treatment, well, a chest radiograph will reveal cardiomegaly and increased pulmonary vascular markings. An EKG may demonstrate ventricular enlargement, particularly on the left, but in most cases it is within the normal range. Echocardiography and auscultation confirm the diagnosis based on the characteristic continuous machinery type of murmur. PDA closure in asymptomatic children with a murmur is recommended because of the risk of infective endocarditis or pulmonary overcirculation that may lead to pulmonary hypertension and eventually develop a right to left shunt. Treatment of a small PDA in a child with an absence of a murmur or other cardiac conditions remains controversial. Premature infants who develop respiratory distress are initially given indomethacin or ibuprofen, both prostaglandin inhibitors, to close the duct. If this is unsuccessful or contraindicated because of renal impairment, surgical ligation and division may be warranted. Historically, the most widely used method for PDA closure is surgical repair involving ligation and division of the ductus, with extremely low surgical mortality. However, there continues to be some morbidity associated with the approach through the left thoracotomy incision. Several other options for PDA closure are available depending on the size of the child and the PDA. Many specialists perform transcatheter closure of the PDA during cardiac catheterization. The catheter is advanced into the ductal opening, whereby coils or other devices are placed into the lumen that prohibit flow through the ductus. The greatest advantages to the procedures are the avoidance of a thoracotomy incision, reduced pain, and shorter hospital stay. Another surgical option is closure through video-assisted thoracoscopic surgery. This procedure involves making 3 small incisions in the left lateral chest wall, through which a tube is inserted. Through the tube, a clip is then placed across the ductus to occlude it. An advantage of this procedure over open surgical procedures is that there is less associated morbidity because of the avoidance of a thoracotomy incision. So what does that leave us with an atrial septal defect? An atrial septal defect is an abnormal communication between the atria. Isolated atrial septal defect occurs in 5 to 10% of all congenital cardiac defects. The three major types are an ostium premium defect, an opening found low in the septum that may be associated with AV valve abnormalities, especially mitral insufficiency. 2. An ostium secundum defect, or an opening in the center of the septum. This is the most common type of atrial defect. Or 3. A sinus venosus defect, an opening that occurs high up on the atrial septum near the superior vena cava and right atrium junction. This defect, often associated with partial anomalous pulmonary venous connection. So what is our pathophysiology? Although the pressure difference between the two atria are minimal, the ASD allows blood to be shunted from the left to the right because of the slightly higher pressure of the left atrial chamber and lower PVR as compared with SVR. Right atrial and ventricular enlargement develops as a result to the left to right shunting. Children with ASD are generally asymptomatic and rarely display signs of pulmonary overcirculation. Moderate to large ASD allow an increase in pulmonary blood flow, and over time, pulmonary vascular changes can occur that may, although rarely, result in pulmonary hypertension. So what clinical manifestations do we see? Well, because most children with ASD are asymptomatic, diagnosis usually is made during a routine physical exam by the auscultation of a crescendo-decrescendo, a systolic ejection murmur that reflects increased blood flow through the pulmonary valve. The location of the murmur is between the second and third intercostal space along the left sternal border. A wide fixed splitting of the second heart sound is also characteristic of ASD, reflecting volume overload to the right ventricle, causing prolonged ejection time and a delay of the pulmonic valve closure. So what's our evaluation and treatment plan in this case? Well, in most cases, an echocardiogram is sufficient to confirm the diagnosis of ASD. A chest radiograph may reveal cardiomegaly and increased pulmonary vascular markings in an asymptomatic child. An EKG may demonstrate right axis deviation and diastolic overload of the right ventricle, manifested as a right ventricular hypertrophy. ASD are generally closed before school age. If left unrepaired, continued left to right shunting through the ASD may result in pulmonary hypertension and right ventricular hypertrophy, placing the child at risk for the development of heart failure, atrial dysrhythmias, or embolic events. Surgical closure involves a pericardial patch or suture closure of the defect, depending on the size of the opening. Repair can be done through a sternotomy or right anterior thoracotomy approach with the use of a cardiopulmonary bypass. Some centers perform minimally invasive techniques for ASD repair in adults and children. Sinus venosus defects require a slightly different approach that consists of a synthetic or pericardial patch to close the opening and baffle the anomalous right pulmonary venous drainage to the left artery or left aorta. Surgical mortality and morbidity are extremely low, depending on the size and location of the ASD. A routinely used alternative to surgery is transcatheter closure, performed in the catheterization lab using various septal occluder devices. In the United States, the Amplatzer and Helix septal occluders are the only FDA-approved devices for a transcatheter ASD closure. Advantages of transcatheter ASD closure include reduced pain, no surgical incision, can be done same day or overnight hospital stay, and the potential complications include rare device embolization, which may require surgical retrieval, and rear device erosion. So then we have our ventricular septal defect. A ventricular septal defect is an abnormal communication between the ventricles. Ventricular septal defect are the most common type of congenital heart lesion and account for 15 to 20% of all CHDs. The four types of ventricular septal defects are based on the location in the septum. The perimembranous type, which occurs in the outflow tract of the left ventricle, immediately below the aortic valve, is the most common type, accounting up to 80% of all ventricular septal defects that require treatment. Muscular VSD, which occurs below or anterior in the ventricular septum between the trabeculae, are most likely to close spontaneously and are difficult to close surgically because of the location low in the ventricular apex. Most macular VSD are hemodynamically insignificant and require no medical or surgical treatment. Supracrystal VSD, also called outlet VSD, occur in the right ventricular outflow tract or infundibulum below the pulmonary valve. Your AV canal or inlet VSD occurs posterior and inferior to the membranous septum, beneath the septal cusp of the tricuspid valve, and the inferior to the papillary muscle of the conus. So what is our pathology or pathophysiology? Well, the direction of shunting in a child with VSD is from the high pressure left side to the lower pressure right side. The amount of shunting depends on the size of the defect and the degree of PVR. Small VSD present increased resistance to shunting and limit blood flow through the defect. Thus, the degree of pulmonary vascular congestion and ventricular chamber enlargement is minimal. After 1 to 2 weeks of life, when PVR is decreased, moderate size to large VSD allow a large amount of shunting from the left to the right. The shunted blood flows directly out the right ventricle, outflow tract, and into the pulmonary artery, rather than remain in the right ventricle cavity. Therefore, the main pulmonary artery, left atrium, and left ventricle all enlarge. Left ventricular hypertrophy occurs to effectively pump the additional volume. Pulmonary overcirculation accounts for the symptoms associated with large VSD in most cases. Over time, the pulmonary bed also undergoes changes because of increased pulmonary blood flow caused by the left to right shunting. The smooth muscle layer in the arteriolar walls thicken, and proliferation of the intiminal layer occurs. The effect of these changes is a decrease in the diameter of the pulmonary vessel, which increases the resistance to blood flow. If the PVR is severely increased, these changes eventually become irreversible, and PVR continues to rise. In some cases, it exceeds SVR, causing the shunting through the VSD to reverse direction. Deoxygenated blood now flows in the systemic circulation, and cyanosis occurs, a phenomenon known as Eisenmenger syndrome. So our clinical manifestations in children with VSD depend on the age of the child, size of the defect, and level of the PVR. Newborns with small VSD are relatively asymptomatic. Initially, no murmur is present because the newborn's high PVR causes equalization of the pressures between both ventricles. Once PVR has dropped, left to right shunting occurs, creating a murmur. Infants with large VSD display symptoms of heart failure and poor weight gain. Adults who develop pulmonary hypertension as a result of unrepaired VSD will be cyanotic and have clubbing. On physical examination, a loud, harsh, hollow systolic murmur and systolic thrill can be detected at the lower sternal border on the left side. The intensity of the murmur reflects the pressure gradient across the VSD. An apical diastolic rumble may be present with a moderate to large defect, reflecting increased flow across the mitral valve. So how do we evaluate and treat? Well, the best case is an EKG and chest radiographs reflect the amount of shunting through the defect. The EKG of an individual with a small VSD may be normal, whereas the EKG of an individual with a large VSD may reveal biventricular hypertrophy and a left atrial enlargement. Chest roentgenographic findings are significant for cardiomegaly and increased pulmonary vascular markings. Again, the severity is directly related to the magnitude of shunting. An EKG identifies the position, size, direction of shunting, and dimensions of the left atrium, left ventricle, and right ventricle chambers. It also can provide an estimated pulmonary artery and right ventricle pressure. Cardiac catheterization may be performed to determine hemodynamics and, in some instances, the location of other defects and additional VSDs. Many VSDs spontaneously close during the first year of life. Infants with symptoms of heart failure and poor weight gain despite medical management should have their VSD corrected as soon as possible. Left to right shunting with a pulmonary flow, systemic flow, ratio of greater than 2 to 1 or evidence of elevated PVR are indications for closure. Closure of the VSD at this time is to prevent the development of pulmonary hypertension. Placement of a PA band to decrease the amount of pulmonary blood flow was initially used as a palliative procedure, but is now rarely used unless the presence of an additional lesion makes complete repair difficult. Patch closure using a synthetic material or pericardium is accomplished through a sternotomy and with the use of cardiopulmonary bypass. A transatrial approach is preferred to a right ventriculotomy because of the increased incidence of conduction disturbances and impaired right ventricular function associated with ventriculotomy. Contraindications for VSD closure include evidence of pulmonary hypertension or Eisenmenger syndrome. Septal occluder devices for perimembranous VSD closure, performed in the cardiac catheterization lab, are not currently available in the US, but are under clinical evaluation in Europe. However, transcatheter muscular VSD devices are currently available for use depending on size and location on the defect. That brings us to atrioventricular canal defects. An atrioventricular canal defect results from non-fusion of the endocardial cushion during fetal life, yielding abnormalities in both the atrial and ventricular septa of the AV valve. This defect accounts for as many as 2% of all CHD, and approximately 70% of complete atrioventricular canal defects occur in children with trisomy 21, or Down syndrome. The three types of atrioventricular canal defect are based on the cardiac components involved. A complete AVC or CAVC defect consists of an inlet VSD, a primum type of ASD, and defects in both the mitral and tricuspid valve. A partial AVC or PAVC defects consists of a primum type of ASD and a cleft in the septal or anterior leaflet of the mitral valve. And then a transitional AVC or TAVC defect involves partial fusion of the endocardial cushions, resulting in variable AV valve abnormalities. So what is our pathophysiology? Hemodynamic abnormalities seen in AVC defects depend on the components of the lesion and the level of PVR. Shunting is minimal during the neonatal period when PVR is high. However, once PVR drops, left-to-right shunting occurs through the septal defects, resulting in increased pulmonary blood flow and heart failure. The PAVC defects mimic the hemodynamic of secundum ASD, in which the left-to-right shunting through the primum ASD causes right atrial and right ventricular dilation and increased pulmonary blood flow. The mitral regurgitation that occurs, caused by the cleft mitral valve, is usually hemodynamically insignificant. Your CAVC defects reflect the hemodynamic of ASD and VSD, resulting in a biatrial and biventricular enlargement. Right atrium and ventricular volume overload occurs because of shunting through the primum ASD and tricuspid regurgitation. Likewise, left atrium and left ventricle volume overload occurs because of the shunting through the VSD. Increased pulmonary venous return and mitral regurgitation. So what are our clinical manifestations? Well, children with PAVC defects are generally asymptomatic. Findings on physical examination are similar to those of secundum ASD, with the addition of holistic regurgitant murmur of mitral regurgitation at the apex. At 4 to 12 weeks of age, when PVR drops, children with CAVC defects usually begin to show symptoms of heart failure. Physical findings are similar to those found in individuals with VSD, with the addition of holistic or holosystolic murmur radiating to the back and apex, reflecting mitral regurgitation. A mid-diastolic rumble at the left lower sternal border or apex reflects relative stenosis of the mitral or tricuspid valve from increased flow. Infants with CAVC may have signs of heart failure and frequent respiratory tract infections. So our evaluation and treatment includes an EKG, generally demonstrates a superior left axis deviation, 90 to 180 degrees. The first degree AV block and right ventricular hypertrophy or right bundle branch block. The EKG of a CAVC defects also may show left ventricular hypertrophy. A chest radiograph shows cardiomegaly, increased pulmonary vascular markings, and a prominent main pulmonary artery. Echocardiograms allows visualization of the components of the defect, including continuity between the AV valves, their size, and chordal attachments. Cardiac catheterization is rarely indicated, but may be performed to evaluate the reversibility of pulmonary vascular disease. Timing of surgical repair depends on the severity of symptoms, degree of shunting, and level of PVR. This trend is to perform complete repair between 3 and 6 months after birth to avoid the development of pulmonary vascular changes. Surgical repair is performed through the sternotomy, implementing a 1 or 2 patch repair to close the septal defects and repair the involved AV valves. Mortality is low unless the child is a newborn, has severe AV valve incompetence, or has univentricular anatomy, an unbalanced AV canal. Postoperative complications include heart block, dysrhythmias, mitral regurgitation requiring further surgical intervention or valve replacement. This leads us to defects decreasing pulmonary blood flow. So defects decreasing pulmonary blood flow involve the obstruction to pulmonary blood flow and septal communications. Because of right ventricular outflow tract obstruction, right-sided pressures exceed left-sided pressure, resulting in a right-to-left shunting. Children with these defects have hypoxemia and cyanosis. Your tetralogy of Fallot consists of 4 defects, hence tetra. A large VSD that is high in the septum, an overriding aorta that straddles the VSD, pulmonary stenosis, and right ventricular hypertrophy is the most common cyanotic congenital heart defect and accounts for 5 to 10% of all defects. So what is our pathophysiology? It is associated with the tetralogy of Fallot, varies widely, depending primarily on the degree of pulmonary stenosis, the size of VSD, and the pulmonary and systemic resistance to flow. Because the VSD is usually large, pressures are equal in both the right ventricle and left ventricle. Therefore, the major determinant of shunt direction through the VSD is the difference between PVR and SVR. Infants who have little or no right-to-left shunting are acyanotic and are known as pink tets. They have a net left-to-right shunt similar to a larger VSD. If PVR is higher than SVR, the shunt is from the right to left. Because many factors can alter the balance between PVR and SVR, shunt direction is not necessarily constant. Pulmonary stenosis decreases blood flow to the lungs and consequently the amount of oxygenated blood that returns to the left heart. If blood also shunts from right to left through the VSD, deoxygenated blood mixes with the oxygenated blood returning from the lungs. The result is low oxygen saturation or hypoxemia in the systemic circulation. The body attempts to compensate for chronic hypoxemia by producing more red blood cells, thereby causing polycythemia, and by increasing blood flow to the lungs through the collateral bronchial vessels in long-standing cases. Our clinical manifestations. In cases with decreased pulmonary flow through the right ventricular outflow tract, as long as the ductus arteriosus remains open, the newborn's pulmonary blood flow may be adequate. As the ductus closes, however, cyanosis becomes apparent. Chronic hypoxemia causes clubbing in the fingers and toes. A rare manifestation of the tetralogy of Fallot is the sudden onset of dyspnea, cyanosis, and restlessness, sometimes called the hypercyanotic spell, or a TET spell, that generally occurs with crying and exertion. The cause of these episodes is unknown, but it is theorized that the right ventricle outflow tract goes into spasm, or the systemic resistance drops suddenly. In either case, the relative or actual increase in PVR increases the right to left shunt and the cyanosis. Hypercyanotic spells are often the events that initiate surgical intervention. If the spells are frequent and do not terminate spontaneously, they are considered a medical surgical emergency. So, infants with the tetralogy of Fallot may have difficulty with feeding because the exertion requires increased hypoxia, and therefore they experience slow growth and failure to thrive. However, most infants with the tetralogy of Fallot grow normally. Squatting is a spontaneous compensatory mechanism used by older children with unrepaired tetralogy of Fallot to alleviate hypercyanic spells. Squatting and its variants increase SVR while decreasing venous return to the heart from the inferior vena cava. The decrease of systemic venous return makes relatively more oxygenated blood available to the body. The increase of systemic resistance also reverses the shunt through the VSD to a left-to-right shunt, which has the effect of increasing pulmonary blood flow. Through both of these mechanisms, squatting temporarily decreases the degree of hypoxemia, Squatting is rarely witnessed because most cases are surgically palliated in early infancy. The typical heart murmur of TOF is a pulmonary systolic ejection murmur caused by the obstruction in the outflow tract, which creates turbulence during systole. More obstruction to flow produces a louder murmur. This explains why the murmur often disappears during a hypoxic spell, when the obstruction increases and pulmonary blood flow decreases to a minimal amount. The second heart sound seems to be single, but in fact it is not. The pulmonary component is very soft and delayed and usually is not heard, although it is present. The enlarged right ventricle may cause the left side of the chest to be more prominent, or a heave may also be palpated. So, what is our evaluation and treatment for the tetralogy of Faux? Well, an EKG indicates right ventricular hypertrophy. A chest radiographic exam shows that the heart is shaped like a boot, upturned apex because of the small main pulmonary artery, and that pulmonary vascular markings are decreased. EKGs and angiograms enable the clinicians to see the size and position of VSD, the stenotic pulmonary infundibulum, or valve, the smaller than normal pulmonary artery, and the overriding aorta. Diagnostic cardiac catheterization is rarely indicated, except to define unusual coronary artery anatomy crossing the right ventricle outflow tract that may complicate surgical palliation. So the current practice is to repair the acyanotic tetralogy of Faux or Fellow before 1 year of age, and cyanotic tetralogy of Fellow in early infancy. Staged procedures include the placement of a shunt from the subclavian or innominate artery to pulmonary artery, known as the modified Blalock-Taussig shunt, or classic Blalock-Taussig shunt, to increase pulmonary blood flow. These shunts may cause the pulmonary artery distortion, but may be necessary in a very small symptomatic child. Corrective repair involves patch closure of the VSD, resection of the infundibular or valvular stenosis, and patch augmentation of the right ventricle outflow tract that can extend across the pulmonary valve annulus. The procedure is done through a sternotomy incision while the child is on cardiopulmonary bypass. Operative mortality is low, and potential complications include dysrhythmias, low cardiac output because the right ventricular dysfunction and occasionally heart block. Many children require further surgery or transcatheter intervention to relieve recurrent pulmonary artery stenosis or treat severe pulmonary insufficiency. More recently, a less invasive treatment for severe pulmonary insufficiency, depending on the size of the pulmonary outflow tract, is transcatheter pulmonary valve replacement, performed in the cardiac cath lab. Alright, so tricuspid atresia consists of an imperforated tricuspid valve, resulting in no communication between the right atrium and right ventricle. This defect accounts for 1 to 3% of congenital heart defects and is the third most common cyanotic heart defect. Tricuspid atresia is a combination of defects, including the imperforate tricuspid valve, as well as a septal defect, hypoplastic or absent right ventricle, enlarged mitral valve and left ventricle, and varying degrees of pulmonic stenosis. Tricuspid atresia also may be associated with transposition of the great vessels. The most common type of tricuspid atresia involves a hypoplastic right atrium with decreased pulmonary blood flow. ASD, VSD, anomally related great vessels. So what is our pathophysiology? Well, a systemic blood returns through the superior and inferior vena cava to the right atrium. Venous return flows through the ASD into the left atrium, mixing with blood returning from the pulmonary circulation. The blood then enters the left ventricle. Most of this blood passes into the systemic circulation through the aorta, but varying amounts flow through the VSD into the hypoplastic right ventricle and to the lungs. Pulmonary circulation depends on the presence of VSD and the presence of a functioning right ventricle of reasonable capacity. If the right ventricle is absent, the pulmonary valve is usually imperforated as well. If this is the case, a PDA is necessary to ensure that some blood flows into the pulmonary circulation. Pulmonary circulation also depends on the relationship between PVR and SVR. As long as PVR is lower than SVR, blood flows through the VSD from left to right, feeding the pulmonary circulation. If PVR rises above SVR, pulmonary blood flow will be significantly diminished. So what are our clinical manifestations? Well, some degree of central cyanosis is common in tricuspid atresia, depending on the amount of pulmonary blood flow. Growth failure also is common. Children experience exertional dyspnea, tachypnea, and hypoxemia. Long-term effects of hypoxia are polycythemia and clubbing. These children also may display hypercyanotic spells. Hepatomegaly may be present in ASD, and restrictive or CHF occurs as a result of increased pulmonary blood flow. The murmur heard with tricuspid atresia may have several components. The VSD causes a systolic regurgitant murmur. The murmur is likely to be softer and shorter as the VSD enlarges. A narrowly split second heart sound caused by decreased pulmonary blood flow may be present. Or the second heart sound may be single if there is a pulmonary atresia. So how do we treat and evaluate? Well, a chest radiographic exam shows the heart size that is normal or slightly increased. An EKG usually shows a right atrium, and left ventricular hypertrophy with a left axis deviation. An echo depicts left to right shunting at the ventricular level. An inability of blood flow to enter the right ventricle from the absent tricuspid opening and the presence of an associated defect. Newborns with ductal-dependent pulmonary blood flow are immediately given prostaglandins to maintain adequate pulmonary blood flow. Treatment is accomplished in stages. Initial surgical intervention involves the placement of a Biologic shunt. If the ASD is restrictive, a Rashkind procedure or balloon atrial septostomy may be performed during catheterization or under echocardiographic guidance at the bedside. Children who experience increased pulmonary blood flow may require a placement of a PA band. Further surgery is undertaken between 4 and 8 months of age, depending on the child's growth and degree of cyanosis. The second stage procedure is the bidirectional Glenn shunt, in which the SVC is anostomized to the PA, or pulmonary artery. At that time, the pulmonary artery may be ligated, and the Biologic shunt is removed. The final separation of the pulmonary circulation to the systemic circulation is the modified Fontan procedure. In this stage, the inferior vena cava blood flow is routed to the pulmonary artery using an intra- or extracardiac tube shaft, or baffle. The procedure is typically performed between 2 and 4 years of age. Surgical outcomes are best in children with normal ventricular function, minimal systemic valve regurgitation, and low PVR. For children with borderline PVR, a fenestration or opening can be created in the baffle or graft to relieve high systemic pulmonary venous pressure if needed. Postoperative complications that increase hospital stay include pleural effusion, elevated pulmonary vascular resistance, and ventricular dysfunction. Exercise tolerance is limited in children following a Fontan procedure, but their general health is usually good. This leads us to our obstructive defects. Obstructive defects. Obstructive defects are conditions in which anatomies, stenosis, or narrowing in either the right or the left outflow tracts obstructs blood flow and results in a pressure load on the affected ventricle. The gradient reflects the severity of the narrowing. The higher the gradient, the more obstruction to flow, and the more afterload on the ventricle. Valvular stenosis refers to stenosis of the valve itself. Subvalvular indicates that the obstruction is below the valve or in the ventricular outflow tract. A supravalvular is the area above the valve, in the great artery. The obstructive defects include coarctation of the aorta, aortic stenosis, and pulmonary stenosis. Symptoms associated with the defect depend on the site and severity of stenosis. The coarctation of the aorta is a narrowing of the lumen of the aorta that impedes blood flow. This defect accounts for 8 to 10% of all congenital heart defects. The coarctation of the aorta is almost always in the juxtaductal position, although it can occur anywhere between the origin of the aortic arch and the bifurcation of the aorta in the lower abdomen. About 50 to 80% of individuals with the coarctation of the aorta have a bicuspid aortic valve and also may have an associated VSD. So our coarctation of the aortic, our COA, may develop because of abnormal contractile ductal tissue that constricts at the time of ductal closure. COA causes a condition in which there is a higher pressure proximal to the site of stenosis and lower pressure distal to the site. In the neonate with a preductal COA, the right ventricle acts as a systemic pump, sending unoxygenated blood through the ductus, right to left, into the descending aorta below the coarctation. As the PVR drops, blood will start to shunt from left to right through the ductus, and symptoms of heart failure follow. In postductal COA, when the right ventricle cannot pump enough blood through the ductus to the descending aorta because of the pressure caused by the narrowed aorta, systolic pressure increases in the ascending aorta and left ventricle and decreases in the descending aorta beyond the COA. In neonates with severe COA, adequate systemic blood flow may depend on the presence of pediate to supply blood flow distal to the obstruction. In long-standing COA, collateral circulation, which involves small arteries arising from the subclavian arteries, joins intercostal arteries that flow from the descending aorta. These collateral vessels bypass the COA and supply blood to the lower extremities. The direction of shunting through the ductus, if present, depends on the pressure presence between the pulmonary artery and the aorta and the location of the ductus. When blood pressure is greater in the aorta than in the pulmonary artery, blood flow through the ductus will be left to right towards the lungs, resulting in increased pulmonary venous return to the left side of the heart. This may place an additional strain on the left artery and left ventricle, leading to increased volume and workload. With time, prolonged left ventricular hypertrophy will cause heart failure symptoms because of increased afterload and obstruction to flow caused by the Coarctation. So what are our clinical manifestations? Our clinical manifestations vary depending on the severity of the coarctation and age of presentation. In newborns, the onset of symptoms depends on the timing of ductal closure after a fall in PVR, the location of the COA, and the presence of associated defects. The newborn usually presents with heart failure symptoms. Once the ductus closes, these infants will deteriorate rapidly and development of hypotension, acidosis, and shock. Older children may not be diagnosed until hypertension is noted. Hypertension is noted in the upper extremities with decreased or absent pulses in the lower extremities. Children may have cool, mottled skin and occasionally leg cramping during exercise. A systolic ejection murmur, heard best at the left interscapular area, is caused by rapid blood flow through the narrowed area. So our treatment and evaluation is as follows. A chest radiograph shows an enlarged heart with congested lung fields in newborns. Ribbon notching between the fourth and eighth ribs may be seen in children older than 5 years, reflecting erosion of the ribs as a result of enlarged collateral vessels from the ascending aorta to the descending aorta, bypassing the coarctation. An EKG may be normal or reveal left ventricular hypertrophy. An echocardiogram will confirm the diagnosis and rule out other intracardiac defects. Cardiac catheterization and/or MRI is performed only if the echocardiogram is inconclusive. The first step in treatment of the symptomatic infant is stabilization, which may require prostaglandin administration, mechanical ventilation, and inotropic support to maintain adequate cardiac output. Once this is achieved, surgical intervention is indicated. Surgical repair consists of a resection with the end-to-end anastomosis of the arc segment, arc augmentation, or subclavian flap aortoplasty technique to enlarge the constricted area. Depending on the arch morphology, hypoplastic transverse arc. A modification of this procedure enlarges the aorta beyond the area of constriction. Cardiopulmonary bypass may not be required in isolated COA, and approach can be through a left thoracotomy incision. However, COA repair may be part of a more complex operation, and a sternotomy incision with a cardiopulmonary bypass may be required. Operative mortality is relatively low. Post-op complications include a recoarctation and paradoxical postoperative hypertension. Residual permanent hypertension requiring continued medical therapy is related to the age at repair. Therefore, surgical intervention is recommended at the time of diagnosis. A percutaneous balloon dilation angioplasty with or without stent implantation may be a less invasive option for treating native COA greater than 6 months of age, or for reducing significant residual COA in most children. However, aortic aneurysm formation and blood vessel injury from arterial access have been noted. That leads us to our aortic stenosis. Aortic stenosis is a narrowing of the aortic outflow tract. The lesion accounts for up to 10% of all congenital heart defects. Valvular stenosis is caused by the malformation or fusion of the cusp. It is the most common type of aortic stenosis, tends to be progressive, and in rare cases can lead to sudden death as a result of low cardiac output or myocardial ischemia. For children with mild aortic stenosis, no exercise restrictions may be needed. For those with moderate aortic stenosis, some exercise limitations may be advised, whereas with severe aortic stenosis, it is an indication for limiting exercise until the repair is accomplished. Less common forms of aortic stenosis are subvalvular stenosis caused by a constricting fibrous ring below the valve, and a supravalvular stenosis that occurs above the valve. So what is our pathophysiology? Obstruction to blood flowing out of the aorta causes an increased workload on that left ventricle, resulting in left ventricular hypertrophy. Left ventricle failure may develop, leading to an increase in left atrium pressure and a backup in the system, eventually resulting in pulmonary vascular congestion and pulmonary arterial hypertension. Left ventricular hypertrophy can decrease coronary artery perfusion, resulting in myocardial ischemia, and can alter the left ventricle papillary muscle, causing mitral insufficiency. Our clinical manifestations, then, in most children with mild to moderate atrial stenosis are asymptomatic. Signs of exercise intolerance may not appear until pre-adolescent. Syncopal episodes, epigastric pain, and exertional chest pain may occur. In more severe forms of atrial stenosis, a systolic ejection murmur at the right upper sternal border that transmits to the neck and left lower sternal border is produced by blood flow through the stenotic area. An ejection click may be heard with a valvular aortic stenosis. Severe forms of aortic stenosis, especially critical aortic stenosis in the newborn, result in shock and require immediate intervention. Diagnosis may be made based on previous medical history and physical findings. Chest radiographic examination may reveal a dilated ascending aorta or left ventricular enlargement. Increased pulmonary vascular markings may be seen in severe forms. In mild cases, the EKG is normal. Left ventricular hypertrophy with strain pattern features that left ventricular hypertrophy with inverted T waves and the lateral precordial leads may be seen in severe forms. An echocardiogram may reveal the thickening or thickened and poorly functioning left ventricle with abnormal structure. Opening and closure of the aortic valve, diagnostic cardiac catheterization is rarely indicated, but may be performed for intervention, such as a balloon aortic valvuloplasty. The presence of ST segment changes in EKG, manifestation of severe heart failure, and evidence of discrete severe stenosis at the aortic outflow tract are indications for intervention. Balloon aortic valvuloplasty is a palliative procedure performed for valvular aortic stenosis. However, it is associated with complications, including aortic insufficiency and dysrhythmias. Children undergoing this procedure almost always require surgical intervention at some time to relieve recurrent narrowing and worsening regurgitation. Surgical treatment for valvular aortic stenosis depend on the severity of the stenosis. Previous intervention and age of the child, aortic valve commissurotomy or valvotomy may be performed as an initial procedure for severe valvular aortic stenosis. Aortic valve replacement or the RAS procedure may be required if the valve is severely dysplastic. Subvalvular aortic stenosis and supravalvular aortic stenosis require surgical repair involving excision of the area causing the constriction. For subvalvular aortic stenosis involving a small left ventricular outflow tract and aortic annulus, a Cano procedure may be required to enlarge that left ventricle outflow tract and aortic annulus with a patch. Severe supravalvular aortic stenosis may require balloon angioplasty and stent placement, or surgical enlargement with coronary reimplantation. That leads us to our pulmonary stenosis. Our pulmonary stenosis is the narrowing of the pulmonary outflow tract. This may be in the form of an abnormal thickening of the valve leaflets or narrowing of the arterial or ventricular side of the valve. Pulmonary atresia is the severe form of pulmonary stenosis and involves complete fusion of the commissures and narrowing of the main pulmonary artery, allowing no blood flow out of the right ventricle to the pulmonary artery. Pulmonary blood flow to the lungs is now dependent on the PDA, or from extra blood vessels, your multiple aortopulmonary collaterals, that arise from the aorta and connect to the pulmonary arteries, and decompression of the right ventricle through the ASD-PFO, or, in rare cases, a VSD for survival. Pulmonary stenosis accounts for 8 to 12% of all congenital heart defects. So pulmonary stenosis creates resistance to blood flow from the right ventricle to the pulmonary artery. The narrowed orifice, or valve, produces increased resistance, or afterload, to ejection. In order for that right ventricle to maintain adequate cardiac output, the myocardium hypertrophies. If that right ventricle outflow tract obstruction is severe, blood may back up into the right atrium, causing dilation. This may result in reopening of the foramen ovale, with resulting unoxygenated blood shunting to the left atrium, causing cyanosis. Clinical manifestations depend on the severity of the pulmonary stenosis. A systolic ejection murmur at the left upper sternal border reflects obstruction to the flow through the narrow pulmonary valve. In some children, a variable systolic ejection click is present, with valvular stenosis at the upper left sternal border. A thrill also may be palpated at the upper left sternal border. Children with moderate pulmonary stenosis may have exertional dyspnea and fatigability because of the inability of the body to increase pulmonary blood flow to meet demands for increased cardiac output. Severe pulmonary stenosis will produce cyanosis and heart failure. The evaluation and treatment. A chest radiograph shows a normal-sized heart with a prominent main pulmonary artery, caused by poststenotic dilation. An EKG is usually normal, but may reveal right axis deviation and right ventricle hypertrophy with moderate pulmonary stenosis. Echocardiographic or echoes will confirm the diagnosis and detects associated defects. Cardiac catheterization, if performed for interventional purposes, further demonstrate pulmonary artery anatomy. Mild to moderate pulmonary stenosis will not likely require intervention, but should be observed closely. Most mild pulmonary stenosis is not progressive. Treatment is indicated with a significant pressure gradient is detected across the right ventricular outflow tract. Critical or severe pulmonary stenosis must be addressed immediately. The treatment of choice is balloon angioplasty. This procedure is considered highly effective in decreasing the pressure gradient across the pulmonic valve and is noted to have few associated complications. Surgical correction involves a pulmonary valvotomy, incising the fused commissures. Both valvotomy and balloon angioplasty may result in some pulmonary valve incompetence. The long-term follow-up may reveal the need for pulmonary valve replacement. Treatment for pulmonary artery depends, or I'm sorry, the treatment for pulmonary artery depends on the size of the native branch, pulmonary arteries, and associated cardiac defects. Initial treatment may consist of an aortopulmonary shunt to supply stable blood flow to the lungs, and later a second procedure to connect the right ventricle to the pulmonary artery. Mixing defects. Many complex defects are classified as mixing defects because of their dependence on the mixing of pulmonary and systemic circulations for survival during the postnatal period. This mixing results in desaturated systemic blood flow and cyanosis. Pulmonary congestion occurs because of the preferential pulmonary blood flow because PVR is normally lower than SVR. Clinically, each defect has varying degrees of cyanosis and heart failure depending on the various component of lesion. So, the transposition of the great arteries. Transposition of the great arteries, or TGA, refers to a condition in which the aorta arises from the right ventricle and the pulmonary artery from the left ventricle. The result is two separate parallel circuits in which unoxygenated blood circulates continuously through the systemic circulation and oxygenated blood circulates repeatedly through the pulmonary circulation. This condition is incompatible with extrauterine life unless a communication exists between the two circuits to provide the necessary oxygen to the body. Communication is accomplished by mixing of pulmonary and systemic circulation through a PDA, ASD, or VSD. Dextrotransposition of the great arteries accounts for 5 to 10% of all congenital heart defects. Dextro refers to the aorta remaining to the right side of the pulmonary artery. Two factors allow newborns with complete transposition to survive long enough to be treated. First, blood from the two closed systems can mix through the ductus arteriosus for a short time after birth if PVR remains high. Some mixing also may occur through the foramen ovale if the child has a VSD. Mixing occurs through that opening as well. The pathophysiology, it is not known precisely what embryologic event leads to the transposition, but researchers have proposed that the fault lies in the development of conal tissue in the fibrous skeleton of the heart. The conus is a segment of muscle that separates the AV tricuspid and mitral valves from the semilunar aortic and pulmonic valves. The fibrous skeleton and heart valves are described and illustrated in Chapter 32. The interventricular septum is intact in about 60 to 70% of cases of transposition. A VSD is present in the remaining 30 to 40%. The following discussion is limited to the pathophysiology of transposition with an intact interventricular septum. So clinical manifestations. The degree of mixing permitted by fetal structures determines the type and severity of clinical manifestations. Cyanosis may be mild shortly after birth or worsening during the first day because of the functional closure of the ductus arteriosus. Low oxygen levels in the blood, hypoxemia, cause metabolic acidosis, tachycardia, and tachypnea. The presence of PDA or large ASD allows for more mixing and results in only mild cyanosis, but the infant may develop heart failure. The first heart sound is normal. The second sound may be heard as a single sound, even though both the aortic and pulmonic valves are functioning. The loud single S2 may occur because transposition places the aortic valve closer to the chest wall than the pulmonic valve. No murmur is noted with transposition of the great arteries with an intact ventricular septum. So the evolution and treatment. On chest radiograph, the heart has characteristic shape, like an egg on its side. The pulmonary vascular markings are increased. The heart may be enlarged if the infant is a few weeks old and has VSD. EKG findings reveal a right axis deviation and some right ventricle hypertrophy. An echo confirms the diagnosis of transposition of the great arteries. Cardiac catheterization or bedside echocardiogram guided balloon atrial septostomy may be needed for additional mixing in children with intact ventricular septum or severe hypoxemia. The most preferred type of surgical repair for DTGA performed in the first weeks of life is the arterial switch procedure. The arterial switch involves transecting the great arteries and anatomizing the main pulmonary artery to the native proximal aorta and anatomizing the ascending AO to the native proximal PA. The coronary arteries are reimplanted with a button of tissue onto the new aortic outflow. Reimplantation of the coronary artery is critical to survival, and they must be reattached without kinking or torsion. Potential complications include narrowing of the great artery, anastomosis, neo-aortic valve regurgitation, and coronary artery insufficiency. Long-term results for the arterial switch operation are usually good. The Rastelli procedure is used in children with transposition, VSD, and severe PS. The procedure involves closing the VSD with a baffle by rerouting left ventricular blood through the VSD to the aorta. The pulmonary valve is closed and the right ventricle to pulmonary artery prosthetic or homograph valve conduit is placed. This procedure requires prosthetic conduit replacement as the child grows and is associated with ventricular failure and dysrhythmias in the postoperative period. This leads us to the total anomalous pulmonary venous connection. The total anomalous pulmonary venous connection, or, or total anomalous pulmonary venous return, occurs when the pulmonary veins abnormally connect to the right side of the heart, either directly or through one or more systemic veins that drain into the right atrium. An ASD also is generally present. This defect is extremely rare, accounting for only 1% of all congenital heart defects. The four types of TAPVC are based on the site of drainage. Supracardiac TAPVC are the most common form, 50%, and drain to the superior vena cava through the vertical or innominate vein. Cardiac TAPVC, or 20%, drain directly into the right atrium or through the coronary sinus. Infracardiac TAPVC, 20%, traverse the diaphragm and drain into the portal or hepatic vein or the inferior vena cava, and mixed TAPVCs, or 10%, are a combination of various types. Partial anomalous venous connection is a condition in which only one or two of the pulmonary veins, usually the right-sided vein, drain into the right atrium or one of its tributaries. So pathophysiologically, TAPVC can be differentiated into two groups, a non-obstructive and obstructive, depending on the absence or presence of obstruction to pulmonary venous drainage. The hemodynamics of the non-obstructive group involve the right atrium receiving the oxygenated blood that would normally flow into the left atrium. The amount of blood shunted into the left atrium versus the volume entering the right ventricle depends on the size of the ASD and compliance of the right ventricle. Therefore, if the ASD is restrictive and the right ventricle compliance approaches normal, more blood will enter the right ventricle than the left atrium, resulting in a right atrium and right ventricle enlargement, as well as an increased pulmonary blood flow. This causes increased pulmonary venous blood return and larger amounts of saturated blood in the right atrium. If the ASD is unrestricted and the right ventricle does not become thinner to increase compliance, the majority of mixed saturated blood is shunted from the higher pressure right atrium to the left atrium. The hemodynamics of obstructed TAPVC causes pulmonary venous hypertension because of resistance caused by the obstruction, resulting in an elevation in the pulmonary vascular and right ventricular pressures. Pulmonary edema occurs from hydrostatic capillary pressure exceeding the osmotic pressure of the blood and eventually contributing to the development of heart failure. This group has a strong association with the infracardiac type of TAPVC and is a surgical emergency. Clinical manifestations include or are in infants with TAPVC is cyanosis caused by a mixture of oxygenated and deoxygenated blood entering the systemic circulation. The degree of cyanosis inversely related to the amount of pulmonary blood flow. Children with unobstructed TAPVC may be asymptomatic until the PVR drops, at which time pulmonary blood flow will increase, resulting in signs of pulmonary overcirculation, particularly slow growth and frequent pulmonary infections, in addition to mild cyanosis. Obstructed TAPVC results in cyanosis and rapid deterioration, necessitating immediate surgical correction or death will occur. Physical exams may reveal a systolic murmur at the left upper sternal border and a mid-diastolic murmur at the left lower sternal border. A murmur may be absent in obstructed TAPVC, a characteristic quadruple rhythm consisting of S1, widely split S2, and S3 or S4, or a gallop rhythm is present. We evaluate and treat thus via an EKG that shows a right axis deviation, right ventricular hypertrophy, and occasional right atrial hypertrophy. The chest radiograph of unobstructed TAPVC reveals cardiomegaly, increased pulmonary vascular markings, and a snowman or figure 8 appearance in the supracardiac type. A chest röntgenogram of obstructed TAPVC shows a normal-sized heart and ground glass appearance of the lung field, reflecting pulmonary venous congestion or edema. The echo reveals an abnormal pulmonary venous connection. Surgical repair varies with the type of TAPVC and whether the defect is obstructed or unobstructed. Obstructed lesions are repaired at the time of diagnosis, whereas the unobstructed type generally is repaired during infancy. The procedure is performed while the patient is on cardiopulmonary bypass and involves anastomosis of the common pulmonary vein to the left atrium and closing the ASD, as in the supracardiac and infracardiac types. Repair of the supracardiac type involves baffling the pulmonary venous drainage to the left atrium. This repair has the highest success rate because of the low technical difficulty, whereas infracardiac repair is associated with a high mortality and morbidity. Potential complications include reobstruction at the anastomosis site, atrial dysrhythmias, including sick sinus syndrome, pulmonary artery hypertension, and left ventricular dysfunction. That leads us to the truncus arteriosus, which is a failure of the large embryonic artery, the truncus arteriosus, to divide into the pulmonary artery and the aorta. This results in a single vessel arising from both ventricles, providing blood flow to the pulmonary and systemic circulation. This common trunk straddle the VSD and has a single valve with 3 or 4 leaflets. which may result in stenosis, regurgitation, or both. The incidence is 1% of all CHD, and a right aortic arch is present 30% of the time. There are 4 types of truncus arteriosus. Type 1 is the most common and involves the main pulmonary artery, rising from the truncus and then dividing into the right and left pulmonary arteries. Type 2 is less common and involves the pulmonary arteries arising from the posterior aspect of the truncus. And type 3, the least common and involves the pulmonary arteries arising from the lateral aspects of the truncus. Type 4, also known as pseudotruncus, is now considered a severe form of the tetralogy of Fallot, with the bronchial arteries arising from the descending aorta to supply the lungs. Type 1 and 2 constitute 85%, while type 3 and 4 constitute the remaining 15%. So what is its pathophysiology? Blood flows from the right ventricle and left ventricle and is pumped into the main truncus, resulting in the mixing of the pulmonary and systemic circulation. The differential flow out of either of the pulmonary bed or systemic circulation depends on the PVR and SVR. Generally, the PVR is less than the SVR, resulting in the majority of blood flow traveling to the lungs. This may be altered, however, because the PS small pulmonary arteries or increased PVR pulmonary vascular disease develops early with this defect because of increased pulmonary blood flow. Physical findings depend on the amount of pulmonary blood flow and the presence of other cardiac anomalies. If pulmonary stenosis is present, a newborn will present with cyanosis caused by already elevated PVR but no heart failure. Conversely, if pulmonary stenosis is not present, the newborn initially will have mild to moderate cyanosis that worsens with activity. Once PVR drops, the pulmonary bed will receive preferential flow and the infant will have signs of heart failure. A harsh systolic regurgitant murmur is usually present along the left sternal border as a result of the VSD, and a systolic click at the apex and a left upper sternal border may be present, reflecting opening of the truncal valve. An apical rumble, with or without a gallop rhythm, also may be present because of increased pulmonary blood flow. If truncal valve insufficiency exists, an early diastolic, high-pitched decrescendo murmur may be present. We evaluate and treat via an EKG generally reveals the biventricular hypertrophy and occasionally a left atrial enlargement. A chest radiograph reveals cardiomegaly with biventricular and left atrial enlargement, as well as an increased pulmonary vascular marking. When pulmonary stenosis is present, the heart size is normal and the pulmonary vascular markings are decreased. An echo determines the type of truncal defect, competency, and truncal valve and differential blood flow. Surgical repair in early infancy is recommended to prevent the sequelae of severe heart failure and pulmonary vascular disease. The definitive repair consists of a modified Rastelli procedure involving VSD patch, closure to divert the blood flow from the left ventricle outflow tract into the truncus. The pulmonary arteries are excised from the aorta and connected to the right ventricle through a tissue homograph, a cadaver conduit. Post-op complications, however, include heart failure, residual VSD, a truncal valve, now the aorta, stenosis or insufficiency, dysrhythmias, and pulmonary hypertension. These children require additional procedures to replace the conduit as its size becomes inadequate in relation to growth, or narrows because of the calcification over time. Our hypoplastic left heart syndrome refers to the abnormal development of the left side cardiac structure, resulting in obstruction to blood flow from the left ventricle outflow tract. Hypoplastic left heart syndrome involves underdevelopment of the left ventricle, aorta, and aortic arch, as well as the mitral atresia and stenosis. Therefore, infants with hypoplastic left heart syndrome must have a well-functioning right ventricle and the presence of a PDA and atrial septal communication for survival. Hypoplastic left heart syndrome accounts for 5% of all congenital heart defects and is considered the most complex congenital defect. Because of the high pressure caused by the left ventricle outflow tract obstruction, saturated blood enters the left atrium and mixes with desaturated blood in the right atrium through an atrial septal communication. Blood flow follows the normal pathway through the right side of the heart, exiting the pulmonary artery. The mixed saturation blood flows through the ductus and to the descending aorta. The amount of blood flow that travels to the pulmonary and systemic circulation depends on vascular resistance in the respective system. Retrograde blood flow through the hypoplastic ascending aorta provides coronary and cerebral blood flow if there is complete aortic atresia. Newborns with HLHS generally are born full-term and initially appear healthy. As the ductus closes, systemic perfusion is decreased, resulting in hypoxemia, acidosis, and shock. Usually no heart murmur is detected and the second heart sound is loud in a single because of aortic atresia. Chest radiograph will show cardiomegaly and increased pulmonary venous congestion. An EKG shows right ventricle hypertrophy and a diminished left-sided force. An echo reveals the components of the defect with a diminutive left ventricular cavity, hypoplastic aortic valve and arch, hypoplastic or absent mitral valve, or an enlarged right ventricular cavity. Interventional cardiac catheterization or echocardiographically guided with balloon atrial septostomy may be necessary if the atrial communication is restrictive. Infants with restrictive atrial septum causing obstructive pulmonary venous return are at high risk for interventions. Prostaglandin infusion to maintain patency of the ductus arteriosus is essential for newborn infant survival. Immediate correction of acidosis, inotropic support for adequate cardiac output, and ventilatory manipulation to balance systemic and pulmonary blood flow prevent further deterioration and achieve stabilization. Surgical intervention includes a three-stage approach that classically begins with the Norwood procedure. The Norwood procedure consists of an atrial septectomy, placement of a pulmonary to systemic artery shunt to maintain adequate pulmonary blood flow, creation of a permanent communication between the right ventricle and aorta, and patch augmentation of the hypoplastic aorta. The cynomodification of the Norwood procedure uses a tube graft between the right ventricle and pulmonary artery to provide stable pulmonary blood flow rather than a pulmonary to systemic arterial shunt. Postoperative complications include imbalances of systemic and pulmonary blood flow, leading to inadequate cardiac output and persistent heart failure. Although the procedure is considered to be high risk, survival in most centers is now averaging greater than 80%. Another option for high-risk infants with HLHS, those with significant comorbidities and prematurity, is the hybrid stage 1 palliation. The procedure involves placement of bilateral pulmonary artery bands to regulate PBF, stenting the ductus arteriosus to provide stable systemic blood flow, and a balloon atrial septostomy to allow unobstructed pulmonary venous return. This procedure can be done without the use of cardiopulmonary bypass and systemic heparinization. However, the second stage, a bidirectional Glenn procedure, will require the addition of an aortic arch augmentation, as described in the original Norwood procedure. The second stage is the bidirectional Glenn procedure, and the third stage is the modified Fontan procedure, which were described previously in the section regarding tricuspid atresia. Long-term health problems following the Fontan procedure are related to reduced ventricular function and high central venous pressures. Few centers perform cardiac transplant as a primary treatment for HLHS because of the scarcity of neonatal donors. Disadvantages of neonatal transplantation includes risk of rejection, long-term problems with chronic immunosuppression, and infection. Infants who are not candidates for staged procedures or transplantations are offered palliative care. Infants with HLHS have improved survival rates because of the advancements in surgical and medical technology. However, many infants and children with complex CHD have long-term neurodevelopmental disabilities. And I think this is where we will call it a stop. We're not going to cover the Kawasaki disease as initially suggested, as well as the additional disorders. Perhaps I will cover them later. Time permitting, we shall see. But as always, I thank you for watching, for listening, for being part of this learning environment. And we shall see you next time when we continue on. Until then, thank you and goodbye.